Thank you.
Thank you very, very much indeed for the introduction, and thank you also to the organisers for inviting me. It's a real honour to be able to talk to you a little bit about risk stratification in children with hypertrophic cardiomyopathy. And what I'd like to do is just touch a little bit on how we can prevent sudden cardiac death, but then really focus primarily on identifying those at risk, so stratifying the risk of sudden cardiac death in this population. And then at the end, I'll just touch a little bit on some of the knowledge gaps that still remain in this field. So there are numerous triggers and substrates for ventricular arrhythmia in hypertrophic cardiomyopathy. So there's left ventricular hypertrophy, hemodynamic issues such as left ventricular outflow tract obstruction, myocardial fibrosis, disarray, which is the histological hallmark of the disease, and small vessel disease. And although hypertrophic cardiomyopathy is much rarer in the pediatric population than it is in adults, sudden cardiac death is still an extremely important clinical problem in this population. In fact, it's probably the most important clinical problem, certainly in childhood. And initial studies had suggested an extremely high rate of lethality in pediatric hypertrophic cardiomyopathy. So sudden cardiac death rates in some populations of up to 10% per year. More recent population-based studies and registries, such as the Pediatric Cardiomyopathy Registry in the United States or our own UK national cohort, have suggested that perhaps, certainly beyond infancy, beyond that first year of life, the outlook for hypertrophic cardiomyopathy in childhood is not as bad as previously thought. But nevertheless, sudden cardiac death is still the most common cause of death in pediatric hypertrophic cardiomyopathy outside that first year of life. And the sudden cardiac death rates that we're now seeing in these populations are in the region of 1.2 to 1.5% per year. So substantially lower than we previously thought, but still about 50% higher than what's reported in adult populations. Now, I think there's evidence now to suggest that in most cases, antiarrhythmic therapy does not prevent sudden cardiac death in hypertrophic cardiomyopathy. And so really we're left with the ICD as the main tool that we have to prevent sudden cardiac death. Now, implantation of an ICD for secondary prevention, so in individuals who've already had a cardiac arrest or who've had sustained ventricular arrhythmias, is a recognized class 1 indication in all age groups. But there's now increasingly available evidence to show that implantation of a primary prevention ICD is effective. It can reduce the rates of sudden cardiac death in children with hypertrophic cardiomyopathy. But this doesn't come without potential complications and risks. And we know that particularly in the pediatric population, there is a high prevalence of complications, particularly related to leads, but also infection and also psychosocial issues to consider. And this is outside the scope or beyond the scope of my talk, but certainly in recent eras, there's been a move towards implantation of simpler devices, so single lead devices or subcutaneous devices for that very reason. But I think what all of these data highlight, though, is really how important it is for us to be able to adequately identify those children who would benefit most from having an ICD implanted. So what do the current guidelines say? So European guidelines and in fact the North American guidelines also really use extrapolation of adult data and quite old adult data to make their recommendations. So in the European guidelines, an ICD is recommended in a child with hypertrophic cardiomyopathy if there are 2 or more so-called conventional risk factors present. So that's severe left ventricular hypertrophy, unexplained syncope, non-sustained ventricular tachycardia, family history of sudden cardiac death. The North American guidelines, including the more recent ones published towards the end of last year, continue to recommend this cumulative risk factor approach. The only difference really is that in the American guidelines, you only need one of these so-called conventional risk factors to warrant ICD implantation. But as I say, these are risk factors that are not really taken from the pediatric population. They're extrapolated from adult data. Does it work? Well, we used our UK cohort a few years ago to demonstrate that, in fact, this approach is not a very good approach to stratify risk in children with hypertrophic cardiomyopathy. What we found was that whilst it is the case that with increasing numbers of risk factors, the prevalence of sudden cardiac death and ventricular arrhythmia events is greater, actually the majority of children who die suddenly or who experience a major arrhythmic event actually have none of those risk factors, or one risk factor at most. And the performance of this approach is a little better than average. So on the ROC curve, the C statistics are in the region of 0.6, so a bit better than average, but certainly not good enough to allow us to discriminate high risk from low risk patients. And so in response to this, a few years ago, we set up an international pediatric cardiomyopathy consortium, which now has data from over 1,700 patients from over 45 centers from around Europe, but also from around the world. And we were able to use these data to develop and to internally validate the first ever personalized or individualized model to predict sudden cardiac death, specifically in children with hypertrophic cardiomyopathy. And this was published a couple of years ago now. And what we did was that we took risk factors that we had identified as being associated with an increased risk of sudden cardiac death in the fairly limited literature specific to the pediatric population. And these are parameters that are very easily available to all clinicians looking after patients with hypertrophic cardiomyopathy, things we measure routinely in clinic. So maximal left ventricular wall thickness, importantly as a continuous variable rather than as a binary variable, so not more than 3 centimeters or less, but actually just the number itself. And also importantly, corrected for body size, which is particularly important in the pediatric population. Left atrial diameter, again, as a continuous variable and corrected to body size. The presence of unexplained syncope, non-sustained VT, and left ventricular outflow tract gradient, again as a continuous variable. And using these parameters, we were able to develop a model that provides an estimate of sudden cardiac death risk at 5 years. And we were able to show in our internal validation that the model works well. So it's good at identifying those individuals who have a high risk. So the correlation between observed and predicted risk is good, but also the C statistic is 0.7, which is very similar to what we see in the adult models. And that tells us that it's a model that is pretty good at identifying those high risk patients compared to those who are at a lower risk. Since the publication of that model, there have been 2 very small external studies that have validated this approach. So there was a study. There was a study from Lidia Solkowska's group in Poland validating this model in a cohort of 78 patients, and more recently a study by Inga Osman-Smith from Sweden, again validating this model in again a small number of patients, but just over 100 patients. And we ourselves have externally validated this model in a much larger cohort of patients, including a large number of patients from the SHARE registry. Now, these data are not yet published, they're under review, but essentially what we were able to demonstrate was that in this independent international cohort, the model performs well. Now, we specifically didn't set out to identify thresholds at which you should implant an ICD, because we feel that the best use of this model is as a tool for shared decision making between patients and clinicians. But if we were to use the 6% threshold, then we would identify over 70% of patients who would go on to have an event. And the C statistic is very similar to what we see in our internal validation and in the adult models. Following the publication of our model, there was a separate model that was produced from the Toronto group, which also estimates risk at 5 years. And there are a number of differences between these models. So our model was larger, nearly twice as large as the primacy model. Our approach to risk factor selection was different. So whilst we used the literature to identify risk factors, the Toronto model uses factors that were associated with sudden death in their cohort on univariable analysis. But actually, despite these differences, the parameters are remarkably similar. So slightly different way of identifying left ventricular hypertrophy. We didn't include age in our model, but when we added it to our model in our development stage, it didn't improve the performance, but essentially very similar parameters and very similar performance also from what we can see. So I think we now have at least a couple of models that certainly work much better than the previous approach and allow us to provide a more personalized approach to risk stratification. But of course, there are still important knowledge gaps. not least the fact that both of these models will need validation in the real world. To this end, our model is available online as a freely available tool to all clinicians who look after patients with hypertrophic cardiomyopathy. We know that hypertrophic cardiomyopathy, particularly in childhood, it includes a very rapidly and significantly evolving phenotype. And so we will need to refine this model to take into account time-dependent variables and serial data. We'll need to look at additional risk factors. So we looked to see whether, for example, using the ECG phenotype could refine this model. In our cohort, it didn't. Osman-Smith's cohort suggests that perhaps inclusion of the ECG score might help to refine the model. So still some work to be done in that respect. There's some evidence to suggest that late gadolinium enhancement on cardiac MRI might help to refine this model. This is from Lydia Solkowska's data. We know that most of what I've spoken about is related to sarcomeric disease, which is the most common cause of hypertrophic cardiomyopathy. But we know that although it's much less frequent, children with rasopathy syndrome, so Noonan syndrome, and some metabolic diseases are also at risk of dying suddenly. So it'll be important to identify risk factors that are specific to those populations. Important also to look at some of the association between some of the individual risk factors and risk of sudden cardiac death, and left ventricular outflow tract obstruction is an example of that, where the apparent association between gradient and risk appears to be different in our pediatric models compared to adult models. And there are a number of possible confounders that might explain that, but important to look at that in more detail. And then finally, I think it's important to remember that although sudden cardiac death is the most common cause of death during childhood, actually, hypertrophic cardiomyopathy at heart remains a disease of heart failure. And there are very elegant data from the SHARE registry to show that, particularly in those individuals who are diagnosed during childhood, there's a significant lifelong burden of disease, which is primarily related to heart failure, atrial fibrillation, and stroke. So important also to consider those outcomes when we think about prognostic models in this disease. So I'm just going to finish there, but before I do, I just want to thank all the investigators who were involved and who contributed data to some of the work that I've presented, particularly the UK pediatric hypertrophic cardiomyopathy investigators and the international pediatric HCM consortium. But thank you very much.
Achim, you need to unmute yourself.
Sorry, Dr. Kaski, thank you very much for sharing your data with us. It's very interesting. Family history and genetic phenotype doesn't counter anymore. Is it? What do you think is the reason for this?
Yeah, thank you for that. It's a very, very good question. So I think the data that we have in relation to the family history of sudden cardiac death suggests that it may not be as important a risk factor in the pediatric population as it has been reported to be in adults. Now, there's a number of possible reasons for that. So it may be that there's a higher prevalence of de novo disease in the pediatric population. It may be actually that what really matters is being a proband as opposed to being a relative. It's possible that some of these children haven't had time to develop a phenotype, and so we're not picking that up when we're looking at the influence of a family history of sudden cardiac death. But certainly the data that we have at the moment, and this is consistent across many studies, suggests that family history of sudden death is not an important risk factor in the pediatric population. In terms of genetics, I think that there have been many attempts to try to use genotype-phenotype correlations in relation to risk. And I think the reason that we haven't yet been able to demonstrate a relationship with risk is because we've been looking at very crude parameters. So we've been looking at genetically positive yes versus genetically positive no. Or we've been looking at the level of the gene. So, is our troponin T mutations associated with higher risk than beta myosin, for example? But we know that there's extreme heterogeneity within that. And so I suspect that there are, and when you look at families, you see this, I suspect that there are correlations between individual genotypes, but it's going to be at the level of individual mutations or at the level of individual domains. And we just don't have enough data at the moment to be able to incorporate that into our models in any significant way. But I think that's definitely something that we and others will be looking very much to incorporate in subsequent iterations of the model.
Thank you. Just one more question for clarification. Maximum wall thickness means systolic or diastolic?
So we always measure wall thickness in diastole, in end diastole. And the important thing to remember here is that it's the maximal left ventricular wall thickness in any myocardial segment. So often people will use M mode to measure the wall thickness and just measure the septum and the posterior wall. But in reality, it's maximal wall thickness in any segment. So we tend to use 2D echo rather than M mode. And we tend to use the short axis views at mitral valve level, at papillary muscle level, at the apex, and measure across all the different segments, but it's end diastolic maximal wall thickness.
Dr. Kaski, there is one question coming up from the audience from Stefan Schubert from Bad Oeynhausen. And he wants to ask you how the right ventricular or left ventricular outflow tract gradient influences the risk stratification for a primary or secondary ICD prophylaxis.
No, thank you very much for that question. That's a very good question. So we haven't looked at the presence of right ventricular outflow tract gradients in this context. So most children with non-syndromic disease don't tend to have concomitant right ventricular outflow tract obstruction. We tend to see that much more in patients with vasopathy syndromes and with metabolic diseases. So we don't have data on RV outflow tract gradients, but left ventricular outflow tract obstruction is included in our model and also in the primacy model from Toronto. And in both of those, it would appear that very high gradients are perhaps associated with a very slightly lower risk than lower gradients are. And that's counterintuitive and certainly different to what we see in adult populations. And I think there are many, many confounders here. So one is the possible effect of treatment. So many of the patients who didn't have obstruction at rest went on to have myectomies during follow-up. So they developed obstruction during follow-up. So it's possible that what we're seeing as a protective and inverted commas effect is actually the effect of treatment of the gradient, but we don't know that yet. And it's possible that some of the patients didn't have sarcomeric disease. They may have had syndromic disease, and but just hadn't been picked up. So at the moment, there's still some work to do in terms of truly dissecting the influence and the role of outflow tract obstruction in risk of sudden cardiac death, and in particular, whether the treatment of outflow tract obstruction modifies that risk.
There's another aspect of the question of Stefan, and he wants that you probably like to answer. What gradient may influence your decision making in surgical resection, like Morrow's myectomy?
So that's another great question, and there are some differences in practice around the world. Our own approach in our center has been that we only treat outflow tract obstruction if it's symptomatic, first of all. So asymptomatic children with a gradient we don't treat, and our treatment is pharmacological first, second, and third. So we tend to treat symptomatic outflow tract obstruction with drugs, beta blockers, disopyramide, calcium channel blockers. And if a child remains symptomatic despite maximal medical therapy, then that would be an indication for surgery. And we don't tend to operate or think about operations purely on the basis of a gradient. We don't have a threshold beyond which we would always offer an operation. The only exception, I think, is where there's fixed obstruction. So where it's not caused by systolic anterior motion of the mitral valve, but there's an accessory cord or a subaortic membrane. In that situation, then we do have a lower threshold for intervening. But in the classical SAM-related dynamic LV outflow tract obstruction, we only tend to treat symptomatic children and only with surgery after medical therapy has failed.
There's another question from the audience as well, and this is from Dr. Castro Sancho. Are there any roles for evidence of increased RV pressure in the risk score to consider?
So that's another good question, and there is some limited evidence from the literature to suggest that perhaps a restrictive physiology may be associated with an increased rate of sudden death, but it's difficult to disentangle outcomes that are related to arrhythmic events and heart failure related deaths in that context. We did not include restrictive physiology or measures of raised pulmonary pressures in our model because there wasn't enough evidence really for it being an independent risk factor, but that's clearly something that will need to be looked at in prospective studies.
I think the question from Regina Bokenkamp has been answered in the last answer from you, because she also reflects to the left ventricular outflow tract obstruction. And to round that up, I'd like to ask you whether you are doing exercise testing with the sign of any depression of the blood pressure during exercise. Is that symptomatic enough for you to consider some active strategy?
So thank you for the question. That is a great question. And certainly in the past, there had been this idea that a flat or a hypotensive blood pressure response to exercise is a risk factor for sudden cardiac death, certainly in young adult populations. In our experience, it's not a very helpful tool at all in children, because a lot of children have quite a flat blood pressure response to exercise anyway. So not just with hypertrophic cardiomyopathy, but just generally. And that's because children tend to use their heart rates rather than the blood pressure to increase cardiac output. So we don't tend to use a flat or a hypotensive blood pressure response to exercise as a risk marker. We certainly do exercise testing routinely in all of our patients with hypertrophic cardiomyopathy. And there are things that we use in terms of assessing functional status and symptomatic status, so peak VO2, VCO2 slope, presence of exercise-induced ischemia, which is often a very important marker, and also exercise echocardiography to look for provocable left ventricular outflow tract obstruction and worsening of mitral regurgitation. But in terms of its role in risk of sudden cardiac death, at the moment it's limited.
Thank you very much, Dr. Kaski. I think due to the matter of time, we have to move on, even though we would have tons of questions to discuss with you. Thank you very much for your contribution.